hernia, where often these babies are considered to be a relative orphan disease. And so we have a lot to learn from each other's experience and expertise. So this is Montreal. It looks like this right now, but it doesn't always look like this. Sometimes we have like a meter of snow. I had the opportunity to visit Australia in 2015, and I remember that it was a beautiful country for the limited places that I had the chance to visit, and I truly hope to come back very soon. So these are my disclosures. I don't really have any disclosures relative to the content of this presentation, except that I want to mention that I will talk about some of the unapproved and off-label experimental or investigational use of some of the medications that we use in congenital diaphragmatic hernia, like inhaled nitric oxide, other pulmonary vasodilators, and cardiovascular medications, including prostaglandin, which really there hasn't been much trial, but I truly hope that as a collective, we'll be investing more into making multicentric trials to better understand how we can implement some of these therapies within the context of the underlying physiology for some of these patients. So at the end of the session today, my hope is that the participants will be able to explain some of the acute pulmonary hypertension phenotypes that we see in congenital diaphragmatic hernia. We'll briefly address the left ventricular phenotype, and we'll recognize that there may be some shifting phenotypes in these patients, as well as an important component of cardiopulmonary interactions. And that's why I'll try to address some of the elements that at least our guidelines within the Canadian setting have tried to address as a multidisciplinary fashion across centers. So I put here the QR code. You're all welcome to scan it. It brings you directly to the collective work we've done in 2023, which was led by Dr. Pramod Poligandla, who's been, for me, a mentor and quite a source of inspiration. He's a pediatric surgeon and pediatric intensivist, and has really, got the whole community of physicians that are involved in the care of congenital diaphragmatic hernia across the country in Canada, and really made a systematic process to try to align some of the practices, both within the perinatal context, the postnatal context, as well as in the long term and during the follow-up, where we know that there's a huge lack of data about what is the trajectory of these patients, what are patient and parent meaningful outcomes that we should be looking at, and the type of resources that we should be investing to support these children as they grow. Now, today, I won't necessarily address all the part about the long term, but I'll try to at least touch base on immediate management of these patients in the way that actually the guidelines have been put together. My role was really focused on the aspect of cardiovascular management, but I was obviously part of the whole discussions for all these different aspects. So I'll start by briefly mentioning what is congenital diaphragmatic hernia, or CDH. It is considered an orphan disease, about 2 to 3 births per 10,000 total births, but it has been steadily increasing over time, potentially with more prenatal diagnosis. And really, it is the thoracic organ that are actually herniating. There's viscera from the abdominal cavity that are herniating within the thorax, and we think that there might be a contribution from this herniation process to some degree of compression to the thoracic organs, leading to them to be underdeveloped. So that includes, potentially the lungs. It includes the heart. It includes the GI tract on its own. But there's been more and more controversy and more research being done showcasing that it might actually be also a component of basically migration defect, where the hole is there, but there's actually anomalies that are either left-sided or right-sided, and sometimes on both sides. And that the contribution of the compression is definitely there, but it might not tell the whole story. And why I say that is that we know that from pathologies, these lungs are abnormal, not just within the ipsilateral side, but also on the contralateral side of the defect, which may mean that there's more to the story than just a compressive effect. There might be an element of actual embryogenic anomalies, vascular anomaly, and as well as potentially epigenetic phenomenon. And so there's a lot of research trying to define better these mechanisms so that we can eventually have better therapies for these patients. And so you will see some of these figures. This is a figure obviously by Dr. Satyan. It was part of one of the recent publications we had in the context of a publication on pulmonary hypertension. And I think, as you can see, one of the hallmark of this condition is that there is really a great interaction between all the organs of these infants. So not just the heart, not just the pulmonary vasculature, and not just the pulmonary parenchyma, but really an intersection between all of these things that may actually create this situation of physiological emergency rather than truly a surgical emergency. We obviously have a defect that we eventually have to correct, because these patients tend to be kept intubated and ventilated on mechanical ventilation and oxygen exposure. And as we know, our babies with fragile lungs will, the longer we expose them to mechanical ventilation, the more there's risk of barotrauma, volume trauma, and hyperoxia being also potentially toxic to some degree. And so the more we wait for surgery, there's probably something that confers an issue. But the earlier you go for surgery for some of these babies, and the more you're at risk of disturbing their transition, which may also lead to potential complications in these patients. So there's really a fine balance in timing and really orchestrating your team in managing these patients. And really it's often a case by case. And obviously these guidelines that I'll mention are trying to at least standardize some kind of criteria that we're able to speak as a common language between the different specialty caring for these patients. So if we strictly look at the lungs, the heart, and the vessels, we know that these patients have some degree of abnormal and hypoplastic fragile lungs, which may be further injured by some of the interventions that we're doing to try to maintain these patients alive. We have some cardiopulmonary interactions that may affect the preload and the afterload of some of the ventricles that we see, on top of having primary issue to the heart based on acidosis, based on the fact that the heart has been potentially compressed during pregnancy and did not grow appropriately, and based on the fact that we're facing adverse pulmonary and systemic vascular afterload. And there's probably also a component that there might be adverse right and left interactions of the heart, where sometimes, and we'll discuss this further, the left heart is being impacted in terms of size and function. And obviously, many of these patients have what we call pulmonary hypertension, or an abnormally high blood pressure in the pulmonary vasculature that may be secondary to many mechanisms, one of them being potentially high pulmonary vascular resistance, one of them being an underdeveloped pulmonary vasculature, so there's a fixed component, and one of them probably being a drainage issue where these patients have some degree of pulmonary venous congestion. And so that's where it becomes important to better phenotype each patient, and more challenging when we try to better study these patients as we clump them into different boxes. And as we know, at 3 a.m., every baby is quite unique in the interventions that we do. So if we go back, CDH has been more and more a diagnosis that we are able to pick up in the prenatal life. It's obviously sometimes more challenging when it's a right-sided CDH because the lung is compressed and has a bit of the liver texture. And so traditionally, a lot of the prognostic factors that we've been using have been based from a large input of the information that we get from the left-sided literature. But there's more and more data outlining also the particularities of patients with right-sided CDH. And so the traditional markers that we've been using, and that at least our guidelines are using to provide some guidance to care in fetal life, has been the observed unexpected lung to head ratio, which, the most severe being less than 25 and the best being above 55. But more and more, we've been using other markers like fetal MRI to predict total lung volume, as well as also integrating other markers that we'll go over briefly. But I just wanted to mention that why is it so important to assess in a comprehensive way and standardized way the way we see these patients in fetal life is that there are potential therapies, first of all, and also because many of these parents are going through a lot of questioning and deserve to have as much as possible information that obviously needs to be tailored to the need of the family that you meet. We know that the group from Dr. Després published about 2 years ago, the total trials where there was fetal tracheal occlusion across a multicentric fashion. These are not perfect trials. They were done across a very prolonged period of time for recruitment purposes, but there are definitely signals that there's potential advantage, especially in the severe CDH fetal phenotype. Now, we don't know if these therapies are actually just improving the overall survival, but also improving the pulmonary hypertension or improving the cardiac phenotype in the long run for some of these babies. But at least there was a signal towards survival. And I think that's definitely one of the outcomes that's been rated quite important for families and for healthcare professionals. So these are some fetal cardiac markers that's been described in the literature. I would say it's been now more than 10 years that we've recognized that some of these babies actually have abnormal growth of some of the left-sided cavities. This is either because there's underfilling of the cavity, but there could be also a component of how there's streaming of blood flow within the heart of the fetus, leading to abnormal growth, as well as a primary issue to mesenchymal migration towards this left ventricle or compression of the left ventricle by the extra cardiac organs, leading to this phenotype of smaller LV. And while this has not trickled in many of our fetal prognostication markers, more and more data are showing that these babies having less desirable outcomes are actually those with smaller mitral valve and smaller left ventricle and smaller fetal aortic valve, outlining that there might be a more severe LV phenotype in these potential babies. The other fetal markers are, polyhydramnias because of a compression effect. Chromosomal anomalies are obviously bringing another layer of complexity. Liver herniation has been something that's been described, and the total volume of the liver herniation is something that we sometimes look onto the MRI. But the issue with liver herniation is that it's a dynamic process and sometimes might be missed. There are other things like obviously having extrapulmonary malformation, like significant congenital heart defect. There's been, case series of patients with, for example, single ventricles and hypoplastic left heart syndrome, which becomes very complex to palliate towards a single ventricular palliation when you have a primary pulmonary vascular issue, because eventually this single ventricular circulation is dependent on very low pulmonary vascular resistances. And I've listed some of these markers below, but I think the important when these patients are being assessed prenatally is to have a standardized way of doing it within your team and making sure that there's a comprehensive assessment as well as sometimes serial assessments to give a better picture towards the care team as well as the family, especially if the center caring for the patient may not have access to ECMO. And at that point, may be more desirable to have the family deliver in an ECMO center. We still are, facing a high burden of mortality in these patients. And when the mortality occurs, it is often because of, respiratory and cardiac failure, or what we call pulmonary hypertension. And so many of these patients will actually have their mortality during the first few weeks, at least the first few days, and then another bunch during the first few weeks from respiratory decompensations. And, although my topic of research and interest has been around the cardiovascular phenotypes and management, I think these babies need to be taken as a whole and as a team approach. In the sense that, family, of course, needs to be integrated, nursing, respiratory therapists, pharmacists, And every individual who will be bringing care to this family and this baby needs to be well thought out, because there's no inotropic or cardiovascular medication that will improve the outcome of your baby if you're not providing excellent, for example, respiratory and airway care. And I think that part of the advantage of putting together the Canadian guideline is that we have this protocolized way of doing things that's been advantageous to all the layer of healthcare professionals that are actually interacting with these babies and families. So I do strongly believe that there's a huge component of cardiorespiratory interactions. And so that's why I think a lot of the emphasis will be today on also respiratory management and cardiac management. But there's obviously much more to the story, and I highly invite you to look at the Euro Consortium CDH guidelines and the Canadian guidelines, and potentially look at your own experience to formulate your protocolized way of approaching these patients. So we tend locally to try to avoid baro-valvular trauma as much as possible. We are careful about secretion management, but we obviously cohort all the care we do with our nurses and team. And we try to be conscious about excessive oxygen supplementation, adjusting a lot of our saturation targets based on the preductal saturation that faces the brain. And so one thing that's important that, our approach, at least at our center, has been that we do resuscitate these patients in 21%. But I know some centers, especially in the US, that will use 100 or 60%. And I just don't think that we have great data on that right now. So this is one of the figures that I find quite telling that's been, and all the credit goes to Dr. Neil Patel from Glasgow. This is from a recent edition on the Seminars of Pediatric Surgery, where we sat down and looked at the trajectory of the cardiac and pulmonary phenotypes of some of these patients. And it's been quite striking that the experience has been quite similar across various countries and continents, where there is a significant portion of these babies who seem to present a quite early phenotype of left ventricular dysfunction, and eventually may shift into a situation with manipulation, with stressors, into this more kind of pulmonary arterial phenotype or precapillary phenotype, where the pulmonary vascular resistances are quite tight, and where this RV is unable to cope anymore due to the increase in afterload. And obviously that's where some of our physiologically driven care might bring some answers to that, while we're waiting for some of the answers related to the trials that have been ongoing. But for example, by modulating the ductus, but still being careful that the duct doesn't become completely left to right and floods your lungs. So reversal of shunting may also be something that's important to monitor, and really trying to integrate some of these biomarkers that we do measure at bedside, like oxygen and CO2, lactate, blood pressure, heart rate, and try to make a comprehensive story as we monitor these patients with a team approach. So locally, we use the TP's resuscitation after intubation in the delivery room. We have not yet formally integrated the late cord clamping, although I know that this is something that is becoming more and more hot press, and it's something that is being currently investigated. But our current guidelines have not advocated for one particular approach, but in general, most practitioners will cut the cord immediately after birth for bringing the baby for stabilization and intubation, although there is a study ongoing for intubation while still on intact cord at the bedside of the mother. We locally use the Canadian Pediatric Society NRP guidelines, starting with 21% and titrate based on the preductal saturation. And we obviously place a nasogastric tube to decompress the stomach, in the idea that we wouldn't want this to further impair the lung expansion and the cardiac transition. These are some of the initial parameters that we aim. So we do aim for a certain degree of permissive hypercapnia to avoid pulmonary injury, but we try to be cognizant that acidosis may also promote pulmonary vascular constriction. We definitely never aim for alkalosis or hypocapnia because of the concern that this may cause further lung injury or brain injury by vasoconstriction. So we typically will keep these patients, if feasible, between the range of 7.3 to 7.35 plus or minus the surrounding area to these values, with a range of 7.2 to 7.4. In the first hour, we do accept lower preductal sats because we think that a blue baby is better than a gray baby. So the idea is that if we seem to have good perfusion and oxygenation to the tissues, at that point, we're happy with preductal saturation in the 80%. And then after that, we aim at around 85 to 90% for some of these patients. We do aim to have a gentle ventilation. So locally, we use a lot of volume guarantee type of ventilation. But if we see that this is failing due to high generated peak inspiratory pressure, we try to switch to a high frequency mode. Typically in most center would go to high frequency oscillation, but I must say that in my center, we've had many patients switch to the high frequency jet ventilator. There's no great data showing which ventilator is more gentle or better. There's been one trial looking at the difference between hi-fi as a start versus conventional mechanical ventilation. And although the trial on its own is also there's no trial that's perfect, but it's already a good data for us to get some sense. It's shown that probably starting with a hi-fi as a primary intention in that particular cohort of patient randomized was not conferring an advantage and was potentially increasing the duration of ventilation. We do recommend in our guidelines to have some light analgesia and sedation, but to avoid iatrogenism, we obviously focus on the idea that any therapy in these patients needs to be titrated based on the response or side effects. And so we do have patients that transition very well, and they're actually on 21% with minimal setting on the vent, and we don't necessarily keep them on this light analgesia and actually wean it completely off. But we have other babies that are more or requiring more cardiorespiratory attention. And in these particular babies, we tend to have a small dose of analgesia and sedation. So I will show some of the tables from the guidelines, and this is really just a summary of the previous elements I've just mentioned. So you can see some of the degree of the strength of consensus among the group and the level of evidence, as well as the guidelines that I just pretty much enunciated in the previous slides regarding the ventilation and CDH. This is other elements adding to what I just said regarding ventilatory settings. So I do give you the reference here of the VICI trial regarding the use of primary intention of conventional mechanical ventilation instead of high frequency as primary intention. And some of the markers that we use to actually ventilate our babies, at least locally. Personally, I will say we would rarely go to a lower PEEP than 5, but that's just our experience. I know centers that would go on much lower PEEP than that, but we've had good experiences with our approach. And so for now, we haven't gone to lower PEEPs, so I'm very transparent with this. I've put here some of the elements regarding what we've established on the Canadian front versus the CDH Euro Consortium. And what you can see is that it's pretty similar across the two jurisdictions, where we do monitor and target similar elements for both oxygen and saturation, as well as lactate levels and urine output as markers of an organ dysfunction. And really looking at some of these other markers like the type of criteria for surgery. We never put, or almost never put, chest tube after surgery because that's been associated with more complication. And we generally try to do surgery after ECMO if they had been on ECMO. So we'll go into more of the cardiovascular phenotypes. I think it's been very well recognized that many of these babies may have a component of arterial vasoconstriction, plus or minus underdeveloped arterial bed, which might not be addressable with pulmonary vasodilators. And so we've been calling this traditionally pulmonary arterial hypertension. As you know, hypertension means high blood pressure, but you know that a pressure is a function of flow and resistance. So I think when we talk about this, we really think about high resistance leading to a high afterload to the right ventricle. And so this high resistance may come with sufficient flow and lead to a higher blood pressure in the pulmonary vasculature. It may come with insufficient flow and actually have a pressure that is not that high. And it may actually come with not enough flow and lead to a relatively hypotensive vascular bed in the lungs that is completely underfilled, yet still facing a very high resistance. And we often face that when it's not going well, when the RV is not able to generate output and to actually maintain the flow within the vasculature. And within this umbrella, we often talk about this RV phenotype where there's very high afterload secondary to arterial capacitance that is inadequate or insufficient. As I mentioned, in recent years, we've been realizing that many of these babies have much more than just an acute pulmonary hypertension phenotype. They have actually some intrinsic LV issues where their LV is either too small or actually dysfunctional. For many years, we thought, oh, it's too small because there's not enough pulmonary vascular flow, leading to low LV preload. But more and more, we realize that even patients who have massive interatrial shunts that would be able to compensate and fill the LV, and even after a certain period of stabilization, some of these babies actually have just smaller left ventricle, and it's probably a component of many different factors that's leading to this, not just a single one. And so as more and more researchers and clinicians are coming together and describing these different phenotypes, we realize that probably we need to also tackle the interventions for these babies in a different ways. There's obviously the transition initially that needs to be taken care of. There's, certain side effects of the complications that we see, like acidosis that builds up into tissues. But also, a lot of the interventions that we do that may also be of great importance. A baby who becomes hypothermic in the OR, a patient who's being in pain due to multiple pokes or due to other nocive interventions, and other elements during the transition that may impact how the RV and the LV are functioning, such as how is your duct maintaining, how big is your PFO or your interatrial shunt to maintain the actual outputs or preloads. All of this may also impact the picture that you're going to see. And this is where I'm going to pitch my own bias, where I do think that there needs to be careful evaluation of these patients. I think we need to be very aware that evaluating or manipulating these babies can be quite detrimental to their transition, but we should also be thoughtful in getting the information at appropriate times, especially when things are not going the right direction. Sorry for this busy slide. I will go over some of these elements in more detail. These are the tables related more to the hemodynamic assessment and the echo assessments in some of these patients. And I will go through some echo markers and phenotypes briefly to give some sense to that. But the guidelines are basically saying that in a situation where you have symptomatic signs of an organ dysfunction or poor perfusion, you should probably get echo, being a non-invasive and without radiation. But I would add that you should get an echo done, as much as possible in the least intrusive way, which means that typically it should be done by someone who has experience in, echocardiographic assessment of these babies, either through targeted neonatal echo or cardiology assessments. Really being focused about where's the big bang for your buck, because this is not a baby you want to manipulate for 45 minutes. This is probably like a very focused imaging in which you want to rule out the major issues, as well as get a sense of the physiologically important variables that will drive the care that you're going to do. Hydrocortisone has been something that's been advocated in our guidelines, and really the strength of evidence is very minimal. It's based from animal studies and models actually of acute pulmonary hypertension, or PPHN, so not necessarily CDH, but it's been shown to potentially potentiate the effect of medications like INO or cardiovascular medication, and may decrease the burden of inflammation in some of these patients. And so it's been potentially suggested as something to be considered in the baby that is really unstable. We do speak about very judicious use of volume repletion, because many of these patients are not volume depleted typically, and more volume may lead to pulmonary congestion as well as tissue edema. And some of the inotropic medications to support cardiac function, or some of the vasopressors, have been listed here, but we'll go through some of the effect of these medications, at least from what we know from physiological information, not necessarily from trials. We do advocate for a few standardized time points. Here you'll see that one should be around 24 to 48 hours of life, unless the baby is quite unstable, and during which you could consider an earlier echo. And the reason why we said 24 hours of life is that more and more there's data that if these babies are doing an adequate transition, it's probably acceptable and desirable to avoid excessive manipulation in these babies. And by 24 hours of age, if these babies are relatively well, that time point seem, in some of the studies that have been done, to be a good time to make sure that we're not missing some of the minor or major cardiac defects, which typically are ruled out during fetal assessments by fetal echo, something that we get in all our patients typically. And what I find to be most important is to outline the degree of cardiac dysfunction, if there is, or the assessment of pulmonary pressures using echo. And so locally, we do follow these patients at around day 5 to 7 of life, and we'll typically repeat one around 2 to 3 weeks of life if these patients are still under our care, to make sure that some of the residual dysfunction or pulmonary pressures have dropped and have normalized. So Dr. Bombal has been one of my mentors when I trained at Stanford, and I think she's a wonderful physiologist, as well as Dr. Patel, and they've outlined really clearly these kind of 3 boxes. But I think what's important to remember is that a patient may shift between these different elements depending on what's happening to the baby, as well as what's happening to the shunts, to the ventricles, to the preload, to the afterload. And that's where I find patients with CDH to be mesmerizing, because you can arrive the morning and have a patient who has significant LV dysfunction, and by the time you introduce therapies to support this left ventricle, you realize that now you may have some degree of RV struggle, or high pulmonary vascular resistance, or high pulmonary pressures. And so I think that's why being at the bedside of these babies and doing judicious assessments provide you with some physiological information to provide as much as possible educated care. So we'll go through some of these potential scenarios. I think the richness in the phenotypes create challenges in research standardization, but it also promotes the idea that we're doing individualized based medicine, and I still think we're able to do research despite that. So we all know the idea of acute pulmonary hypertension, or PPHN, where these patients have right to left shunting at both the both the ductal level and the atrial level, typically a phenotype where the PVR are high. Because of that, you get less left atrial filling due to low pulmonary vascular flow. This promotes hypoxic blood entering your left atrium, leading to preductal systemic desaturation. And often these babies will have large ducts, and depending on the volume that is going through this duct, you may introduce a lot of hypoxic blood into the descending aorta, which maintains output and perfusion to the distal limbs, but makes a baby, quite hypoxic with pre and postductal desaturations. So these are some echo views where you see a pulmonary artery and an aorta, and you see this right to left shunt through this duct. And similarly, this is a subcostal view with a right and left atrium, and you see this right to left shunt. When you see that, you obviously always want to make sure you're not missing a total anomalous pulmonary venous return, because that would be really bad if you miss it. And when you see that, you always want to take into account what's happening on my pulmonary end and on my systemic end, and what is exactly driving this directionality. Is it that I have high high vascular resistance here and low vascular resistance here, high here, normal here, but very low here? So obviously the relationship between your pulmonary and systemic compartment are still very important to take into account when you're going to introduce therapies. The progression of the phenotype will typically be in a situation where you start having this pop-off or this duct become more and more smaller, which will prevent the equalization of pressure across the two compartments. Because as you know, two boxes that are connected through a big channel will equalize pressure. And so as you're closing this duct and restricting its pressure transmission and flow, if you face high pulmonary vascular resistance, well, flow will be forced into this high PVR and pressure will rise, leading to high afterload, and this RV will start, facing this very high bench press, basically, and maybe failing. These patients will sometimes be profoundly desaturated because they have a very high volume shunt at the atrial level, bringing a lot of hypoxic blood into the left atrium due to the RV failure. And they may or may not get postductal differences, because if this volume here of blood flow, if it's only 3 or 4 RBC going through this duct, you will not see clinically the difference in saturation. And so that's when this duct become restrictive. And these patients could be quite ill because they may eventually suffer low LV output due to the low LV preload. And that really depends on actually how big and large this interatrial shunt is. So the baby will become more blue if you get a lot of right to left shunt at the atrial level, and become more gray if you actually are not able to maintain the preload to the left atrium. So these patients actually look like this. They have, large angry RVs in the apical view. They start having dilatation of the tricuspid annulus and a lot of TR, which allows you to get some estimate of RVRA gradient. But you can see that, often these babies will have right ventricles that are struggling. And so that's a lot of babies where we start thinking about potentially supporting the RV function and even giving pulmonary vasodilators, although we know that INO has not been the miraculous drug in patients with CDH, at least within trial context. This is another example of this patient where you see a parasternal short axis view where the RV is dilated and you get septal bowing at the peak of systole, outlining that this RV is likely suprasystemic, or the pressure within it are larger than the pressure within the LV. And you can see this duct that is quite small, which is actually bidirectional. So there's a portion of the cardiac cycle where the pressure might be lower. And I think that this is because of lower flow within the actual pulmonary vasculature. But you see that after the QRS and systole, the directionality is right to left, and there's a relatively high gradient. So 33 millimeters of mercury of estimated pressure difference, outlining that this is suprasystemic at that point of the cardiac cycle in systole. Now, if you have a dead left ventricle, obviously you don't get output. And because of that, you may get to see a left to right shunt at your ductal level. So these patients will definitely not have pre and post ductal saturation because your RV is basically non-functioning. And so you're dependent on your LV to send blood flow to your systemic circulation. And a bit of it goes actually to the pulmonary artery and feeds this pulmonary artery because there's basically no output through the RV. These babies are not doing well at all. Typically, they're very blue depending on this atrial shunt because you get a lot of backflow into the right atrium. And so at that point, these are patients that really require some support in terms of inotropy of the ventricles. So we often call this in the jargon functional pulmonary atresia or functional pulmonary stenosis, because it's not that the valve is closed or that the RVOT is obstructed. It's just that the RV is not generating enough flow to be able to open sufficiently the pulmonary valve and inject within the outflow tract. So this is an example of a patient who has a significant right to left shunt at the atrial level, very, very low output at the right ventricular outflow tract, and basically an underfilled pulmonary vascular bed leading to this very small PDA being left to right. And so in these patients, that's definitely a patient in which you may want to consider something like PGE to actually sustain the flow into the pulmonary vasculature. Another phenotype in acute PH is when you do not have a duct. So obviously the patient at the extreme, when you start closing your duct, well, you might get significant RV failure if you have high PVR. You won't see pre and post ductal saturation differences because there's just no duct. And you may have a baby that's very hypoxic because a lot of blue blood enters the systemic circulation at the atrial level. So these patients, at the ductal view will have no duct. They'll have right to left shunt, and they'll typically have very angry right ventricle that looks very dilated, sometimes a bit more, hypertrophied, and barely moving on the longitudinal axis because they're facing very high afterload. And in these patients, giving PG may or may not work. It depends how long this PDA has been closed, but typically most of our CDH babies will have had a PDA at least in the immediate postnatal life, and it's usually responsive to PG. Now, we know many babies may also have some contribution of LV failure. And so when you have LV failure, what happens is that these patients actually are often not so bad on the preductal level, because what we see is that these babies have high left ventricular and diastolic pressure. This backs off into the left atrium, which increases the LE pressure. And because the left atrial pressure is high, it will actually pop off into the right atrium. So you really don't get hypoxic blood entering your left atrium by shunting right to left. So often many of these babies will have left to right shunt at the atrial level, or significant bidirectional shunt that is mostly left to right. But because the LV is struggling and not generating great output, you may have a situation where you get right to left shunting at the ductal level because they may have a component of high PVR relative to the low output into the LV. And so these patients may actually send blue blood into your systemic circulation, leading to these pre and post ductal saturation differences. But contrary to our previous babies, many of these babies will actually have very nice pre-ductal sat, like 90 to 95%. The only reason why they would have bad pre-ductal sat is in situation where your lungs are not doing great. So pulmonary edema, pneumothorax, you had meconium at the same time, or you get a lot of atelectasis in your CDH baby. And so obviously if you get VQ mismatch in your lungs, whatever is coming back through the pulmonary veins will be desaturated. And so the baby may be blue in the preductal limb as well at that point. So, but just a key reminder that if you see a baby with CDH who has beautiful preductal saturation and a left to right shunt at the atrial level, think that the LV may have some component of struggling in this picture. So they will typically look like this, where they have, very, struggling LV. This is a very obvious example. They have this little PFO here. So this is a subcostal view. So you have a right and a left atrium. And when you follow the arrow, that means that it's coming towards the probe and it becomes red. So it's a left to right shunt. And you can see here that the duct is shunting from the pulmonary artery to the aorta. And just because I know that Professor DeWall really, also does a lot of research using technologies like strain. This is one of our patients here who had CDH, and you can see that, left ventricle in the first few hours of life in this patient was actually quite ill, looked really struggling. And, I don't even think that we need strain, but we did use strain in this particular baby. And you can see that, the estimated EF in that context was extremely low. So this baby was supported with cardiovascular support. And in this particular context, we used some degree of adrenaline or epinephrine to support that. But there's many, many variations to the picture. Do you have a smaller no PFO, which would be very unlikely in a baby? Is the duct becoming restricted? Is there concomitant underfilling because the mom bled during the delivery process? And is there concomitant pulmonary parenchymal disease? And don't forget that what you do on the respirator, such as very high PEEP or very high mean airway pressure, may also impact a lot the afterload of your right ventricle by squeezing this pulmonary vasculature, as well as leading to changes in your intrathoracic gradients, which may also impact your output. I've put here some of the studies that have been described with postnatal various dysfunction. One of the study that I did at Stanford was, outlining that actually the LV dysfunction was really predictive of the outcome of mortality or ECMO. So I put some really nice graphs there. They're meant for your references from really another great article here, which talks a lot about also the concept of ventricular interdependence. So obviously, if your RV is becoming like a balloon, you may start impeding your LV, which is within the same constraints and is sharing a wall, as well as some muscle fibers. And so obviously, as a couple that is densing, if you have an LV and RV failure, eventually you may lead to failure of the other component. I'll skip this. And this is just a reference of the two papers that we've done when we were at Stanford under the guidance of Shazia Bombao, looking at the LV in CDH patients. And my colleague in the UK, so Neil Patel, had described similar findings in their own population. So bringing you back to phenotypes, I've put this figure here where you can see that depending on the phenotype, there might be various strategies that you can implement. I think this one talks a lot about what are the physiologies and what are the therapeutic strategy without necessarily specifying a drug, because I think, many different units may have different comfort level with different medications, and we just don't really know which one is better. Is dobutamine better than epi? Well, maybe if you're extremely tachycardic, dobutamine may not be the best because it's, pro-arrhythmogenic, versus epi, maybe something that's causing more side effect at the level of sugar and lactate levels. So these are all things that you need to take into account. They're great drugs to support us, but they're also toxic to some degree. And so we have to titrate them and be very cautious with them. So in the last few minutes, I have 10 minutes. I've put some slides about some of the assessments we do by TNE, or targeted neonatal echo, or neonatologist performed echocardiography. This comes from this comprehensive review. So I don't want to bore your life, but I've put some of the tables and I'll make these slides available. But basically, you'll see that, we basically assess pulmonary pressures, function of the RV, function of the LV. And we try to get as much of comprehensive information, but we obviously try to tackle the most important elements to be efficient when we do these assessments. So personally, when I do these particular scans, I look if I can get a TR, a ductal flow pattern, and I look at my septal curve, although it's imperfect, but we can use also what we call the eccentricity index in that particular context. The TR informs you on the RV systolic pressure estimate. And so it gives you some information about what's corresponding to the pulmonary artery and systole when these two chambers are equalizing pressure. I'll skip this. The ductal flow pattern informs you a lot on the relationship between the PA and the aorta. But obviously, this has to be taken into the context of the clinical of what's happening in your systemic vasculature. So you can see that you can have restrictive bidirectional or completely unrestricted, very large PDAs. Or you can have completely right to left duct that are very tiny. And eventually, when you introduce potentially PGE and reopen this, you start getting very low velocities. But this is at the expense of you get more hypoxia to your patient. I'm going to skip these slides. Septal curvature, we have outlined in the previous phenotypes. Obviously, the two ventricles are connected to each other, and there's a degree of septal flattening that may be increasing depending on the relationship of your two compartments. And so you always need to put together what's happening on the right-sided cavities or the pulmonary side and the systemic side to be able to interpret the septal motion, the PDA, and the VSD. This I'm going to skip. I've shown you here some example of biventricular dysfunction, and I really want to get to a point where we have a chance to chat on questions. I'm not going to go over all these indexes of LVO, RVO, and LV function because I think this can be addressed in other contexts. We do use a lot of strain, mostly in our research program. This is what we call speckle tracking, which allows you to assess deformation. And it really looks at the motion of the myocardial wall and allows you to get more granular information about activation as well as the degree of shortening of these walls. And so you can implement this technology to both the left ventricle as well as the right ventricle in the different views. And so right now we're assessing further our own cohorts of CDH at different time points using this technology to see if this could be something that really provides us more insight about the phenotype of these patients. I will just skip this. Yes. So what about the management? Briefly, I think depending on the phenotypes, you may adjust what you do. We will obviously constantly monitor the hemodynamics at each care, and our nurses are very diligent about this. We do very judicious use of fluid resuscitation. It's typically not something that's part of our first initial steps in these patients, to be honest, because we don't really think that these babies are underfilled. And then we do use echo to target the therapies that we do in these patients with respiratory and hemodynamic instability. So my tips are: avoid excessive manipulation, avoid too many people in the room, have the most experienced personnel to care for these newborns, make sure you have a multidisciplinary management, really try to have those basic things like silent room, calm, dark, presence of parents, and avoiding too many skin breaks. So in our particular population, we do use umbilical arterial line to try to minimize the blood samplings that may be painful. In patients with some degree of PAH, we still use INO even if the trials have been quite disappointing. There are countries that may not have INO and they have sildenafil. The issue with sildenafil is that it will be given typically enterally and intravenously. And because of that, you may have systemic side effects and you may have a lot of VQ mismatch. We will sometimes consider for inotropy things like epinephrine and dobutamine, but I particularly prefer epinephrine in these babies because of the risk of tachycardia leading to issue with filling in some of these struggling ventricles. And if the LV function is preserved and the patient has vasomotor instability, there are more and more centers using things like norepi and vasopressin, but it's typically not something that locally we've used a lot in these particular CDH babies because we're always concerned that their LV might be struggling. I think PGE should always be in your back pocket when you're facing RV or LV dysfunction, especially if you're concerned about the output and that your PDA is very tiny. But obviously be aware that this drug also can cause hypotension and vasodilation in the systemic compartment, and that if you have a strict left to right shunt at some point, you may worsen your coronary perfusion as well as your pulmonary dynamics. So I've put some tables with some of these concepts of pulmonary vasodilators and inotropic support. And I did put a summary table of all these other agents that you may consider and their effect on SVR, PVR for your reference. I'll be sharing these slides, obviously, with Professor DeWall. This can be found on the Neocardio Lab, which is my website, under the inotropic section, and has a bit more detail than the previous table. And pulmonary vasodilators, I just want to finish on this note that we just really don't have great data about the effect of selective pulmonary vasodilators. And really the cumulative data that we have is really on INO, which is inhaled, which the hope is that it may help also some degree of VQ mismatch. But all these other drugs have mostly been studied in the context of adults or pediatric pulmonary arterial hypertension. So to finish with the guidelines, this is again, PGE being used as something that can sustain pulmonary or systemic blood flow, especially in the context of RV failure, suprasystemic right ventricular pressure, or LV dysfunction. And some of these other drugs I think I have mentioned when I've discussed some of the cases. So in conclusion, I think in these babies, less is often better. Judicious use of any cardiovascular strategy should be stepwise in these babies. Multidisciplinary care is particularly important because I think that the devil's in the details, especially when we think about the cardiorespiratory interactions. And when you do need cardiac support, I think right now the best that we have is individualized care targeted by underlying phenotype, knowing that this phenotype may change over time. And beware of creating iatrogenism, because many of these babies, I do strongly believe that less is often better. This is the CDH team at the Montreal Children's Hospital. We have nurses, respiratory therapists, GI, neonatal follow-up, surgery. So I highly encourage to create your own team if there's not one at your own center. And I want to thank all the organizations supporting my lab. I've put here the links, my emails, and if you have any questions, comments, or insults, I'm open to all of those.
Thanks, Gabriel. That was a great overview, and indeed, you summarized that you can create improved outcomes through collaborations. And with this particular disease, it is a fantastic example how the research in the last, I would say, 10 to 15 years has, skyrocketed with increased understanding of physiology and collaboration between fetal maternal medicine, radiologists, pediatric surgeons, intensivists, and cardiologists, or ultrasound sort of information. You then highlighted quite a lot about these, what you call phenotypes, basically the different physiological scenarios, which will all create hypoxia. And then you explained in physiological terms, it could be preload, afterload, and that pulmonary hypertension is not just the pressure, it's either flow driven, resistance driven, or left ventricular dysfunction driven. And then you went on, and I thought it was a really good message and you showed the examples how your pre and post ductal saturations, although sometimes very helpful, but a lot of times, and particularly in diaphragmatic hernia, can be very confusing if you don't have the imaging information behind, what happens on left atrium level and what happens at the ductal level, the shunts. And then you showed all the ultrasound images, and it was clear, particularly to the beginners who start, this is not POCUS, this is not point of care ultrasound. You need a lot of information, including more advanced techniques, multimodal technologies to give you all that information. And I do agree with your tip in these particular babies, just ask an experienced person to do the scans and give you that information in the shortest period of time. All right, so I'm opening the floor to some questions. Arvind, do you have some questions you want to open up?
Well,
I see there's some questions in the chat.
You asked to write in the chat box. Anyway, so look, Gabriel, thanks. Wonderful talk, and it's always great to see a lot of videos. It just creates a very different impression than simple words in a slide. So my questions really are two. So in a scenario where nitric oxide was started in a baby with modest or no improvement, how anxious does it make your surgeons to operate? Do they insist that gradually wean off nitric, then we operate, or they are semi-comfortable with, of course, hemodynamic staff with hemodynamic expertise in close proximity to operate that? Second is, we generally start Prostin actually electively at 10 nanograms, more as a, really in the preoperative period, helps to kind of keep the duct patent and decompress the right ventricle, but also mild pulmonary vasodilator effect. So yeah, totally. Those two comments in question, mainly around the nitric oxide and surgical comfort.
So locally, I would say, I didn't go into the surgical readiness, but that's one question also in the chat, and it ties a bit with your question, and thank you. That's always a great question, and I think there's many controversies across the globe about INO, for example, and what to do with it in the surgical context, the time in the ECMO, and all these things. Our guidelines actually in Canada has been that we should achieve certain types of physiological stability before rushing these babies for an operation. So typically in our context, we've been waiting usually the 24 to 48 hours trademark, and then we see, are these babies urinating well? Is the FiO2 is not excessive? Are we able to maintain good perfusion with low lactate levels? And if so, we actually consider these babies ready for surgery. And some of these babies may be on nitric and they may be on PGE. Now, that being said, when this is the case, this is the kind of baby that we will operate in our NICU under our care during the operation. So it is a team effort. Anesthesia comes and stays with us in the room during the operation. But actually, a neonatologist is there. We don't move the baby to the OR, and we actually have a room that is adapted for the cycling of air and everything. It's just to avoid transport, change between teams. Oh, you're using these drugs, I'm going to use these drugs. And we've seen great success with that. And so we use INO and we use Hi-Fi and we use JED during the operation and the repair. Now, of course, for our team of surgeons, they feel much more comfortable in our own environment. So the baby who's on 21%, who is not hemodynamically unstable or unstable in a cardiovascular perspective, will typically go to the regular operating suite and will get its operation by the surgeon in their comfortable environment, because we're less worried about high PVR becoming uncontrollable during the operation. But it's in these babies that you described that are still on INO and they're achieving a nice transition, but they needed that kind of extra kick with the INO. We are typically more reluctant to move these babies and send them far away from our NICU and from our care. So we're a bit like I would say micromanagers of these babies in some way, but we do operate on INO some of these babies. And we don't necessarily wait for all of this to be weaned off, because then we're always conscious that the mechanical ventilation may also bring some issues of inflammatory changes and damage to these lungs that are hypoplastic. And then you're stuck into like the cycle of mechanical ventilation injury and even more inflammation and even more PVR. So it's always this balance. And I would say that our particular approach, which I'm not saying is better than any others, but has been to sit down on a daily basis, assess the patient, and if we see that the baby is on INO but in a good place in terms of perfusion, oxygen needs, output stability, we will proceed with the operation at that point. So that's for this. We are also fan of prostaglandin. We are careful in the sense that we will initiate them in babies in which we see that there's some degree of cardiovascular compromise. We typically don't start it as a prophylaxis, although I have a bias that is very positive towards them in these babies, because I find that the most severe patients that have been predicted to have co-arched and small arch because they have such small LVs, and they're started immediately on PG after birth. And they've been doing great in our unit, actually. These babies actually, go through and they do quite well. So I do have a bit this bias about PGE. Sadly, I cannot back it up with great trial evidence. I do hope one day that we will have trial evidence on this. The only thing about PGE is that once we start babies on PGE, our practice has been to monitor them quite frequently, at least once a day, because we're always worried that the duct is going to become massive and then suddenly the PVR to SVR ratio is going to be unfavorable towards flooding those lungs. And then we get into the mechanical ventilation issues with pulmonary edema. So as soon as we see that these PDAs are becoming less desirable in their profile, that's when we start titrating down or stopping our PG in these patients. But I do have also that bias that I find that it has a bit of that pulmonary vasodilator kick and maintains this shunt between the two circulation to maintain output, definitely. Hopefully I answered your question. Yeah.
That's a good point, Ted. Lots of diseases, and particularly diaphragmatic hernia is quite dynamic. And I really like your slides where you show, the different time frames and the different physiological stages which a diaphragmatic hernia will go to. We're a bit over time. I'm going to do this last question, so from Deeper Eyes. It's about timing of surgery. You highlighted a little bit on it. Yeah, if all these values are stable, sure, that's an easy one. What if they're not stable?
Yeah, so I'll just maybe share again quickly my screen. I did put the QR code that brings to the guidelines, but in our consensus, it's been that surgery should be considered if a patient fails to meet surgical readiness criteria after 2 weeks. Again, I think a lot of the consensus amongst the groups in Canada has been this scare that if we don't operate at some point, they're going to be stuck on the ventilator, and then we may create even more iatrogenism. Of course, we live in an era of individualized care and precision medicine. I think, in our experience, it's been very rare. The only patient I know in our practice that we operated further than 2 weeks has been a premature baby born at 26 weeks who had a severe right-sided CDH and who was obviously not ready at 2 weeks of life for this major operation. And so, in these patients, you need other consideration. And obviously, this baby ended up getting operated closer to 32 weeks. Some centers would have not even operated at 32 weeks and would have waited for maybe ECMO criteria candidacy before operating in case the baby would be unstable post-op. But we saw a lot of damage and inflammation starting to get settled into the lungs, and we got quite scared about that. So I think in the gist of patients, in the majority, most centers have agreed that if at 2 weeks of life, you're still in a situation that you're stuck on high oxygen needs, that you are in a situation that your baby is requiring significant cardiovascular support, but you're still not operated, many of our colleagues will go and provide a surgical correction to these babies. But surgery is never the same, right? Like, what you do in an emergency setup with minimal manipulation and you have a really short time window might be very different when you have a baby who's very stable. So it has to be kind of pre-planned, who's going to be there, how you're going to be doing it, what's going to be the setup, temperature, medication, anesthesia, like all these things coming together. So it might not be necessarily in your NICU if you don't have the appropriate setup, but I do think that these babies really benefit from having teams working together and not just doing a transfer of information. Ciao, bye, take care of my patient who's on 100% oxygen. It has to be that the team mobilizes and work with anesthesia together to really promote the best moment of care for the surgeon, stability, and kind of knowing what's happening during that time point. How much fluid are we giving? What is the drugs that we're infusing? Because this patient is going to come back under your care. And maybe if this baby received like 200 cc of, crystalloid, then maybe you're going to be stuck with another problem after that. So it's these things where I mean that devil is in the details. And I do think that communication and working in team is key at that point.
All right, well, thanks, Gabriel. Thanks for staying up and bringing us this wonderful overview, and I hope to see you soon again. For everybody, thanks for attending. Next week, we have another session from Professor Cynthia McAvoy, who's going to talk about the role of CPAP and lung development. So hope to see you all next week. Thanks again, Gabriel.
Thank you so much for having me. It was a pleasure, and